the young people with self-harm. Now, when you look at suicide around the world, you will see that there are different trends. This is obviously pre-COVID in different countries. So the countries that look yellow, brown to sort of deep brown, they experienced an increase in suicide rate, whereas the countries with sort of green, blue to dark green colors are the countries that reported fewer suicides, so the trend towards reduction of suicides. You will see that pre-COVID, the UAE was one of the countries with relatively low suicide rate, but actually reporting an increase in the prevalence. Now, when you look at different age groups in relation to suicide around the world, then you will see that in the vast majority of countries and regions, you would expect an increase in suicide over time. And so the oldest people in each population would be at the greatest risk of suicide, with one notable exception of Southeast Asian women, where we have an unusual bimodal distribution of suicide prevalence, with very young women and very old women being at equally great risk of suicide. When you look at European prevalence of suicide, then it is clear that it's mainly the Baltic, East European, and Northern countries that experience significantly more suicides in young people than Mediterranean and Southern countries. It is probably not fully explained by biased reporting, and almost certainly reflects some underlying differences in suicide rates. In the UK, we have seen a gradual decrease in suicide rates in both males and females. You will know, most of you will know that male to female suicide rate is something like 3 or 4 to 1 in most Western countries. But you can see that both the male, which is the green line, and the female, which is the dark blue line, suicide rates have been gradually reducing over many years in the UK. When they hit a plateau around 2011, 2010, then there was a plateau with some increases, but then in the last 2 years before COVID, so the last data available is 2019, we have seen a fairly sharp increase in suicide, especially in males, but overall as well. When we look at the method of suicide, then the key method of suicide in the UK in all age groups is hanging. Now, you can see on the left that hanging is by far the most common method of suicide in males. In females, something very interesting happened where as recently as early 2000s, self-poisoning was the key method of suicide in females. Then around 2009, 2011, there was parity, so females were killing themselves by self-poisoning or by self-hanging equally. And then since about 2013, there was a definitive increase in the suicides by hanging in females. And that gap keeps growing. When we now look at youngest boys and young men, then when I trained, we were told that we are really experiencing the peak of that, and it is true. If you look at young suicides, then sort of late 80s to late 90s was the time with the greatest prevalence of suicide in young males, which was then reducing very dramatically for many years, except as I said in the last 2 years when there was an increase in young male suicide, with a plateau last year. In females, in young females, it's even more dramatic, even though, of course, the absolute numbers of suicides are significantly lower in females. Then in young females, we have seen the highest prevalence of suicide last year of any year since the records began. So there's something very worrying happening to young women and girls in the UK, and that is replicated in many other countries too. Now, the reason why we talk about self-harm in conjunction with suicide is because, as far as we know, self-harm is the strongest known predictor of suicide. For the purposes of this lecture, self-harm will be defined as either non-suicidal self-injury or suicide attempts. So using the UK definition, we think about self-harm as any kind of self-poisoning or self-injury, irrespective of the intent. It's a long debate that has been going on in academia for many years, but that's the way most researchers in the UK think about self-harm. So any self-injury or self-poisoning, irrespective of the suicidal intent. So if we define self-harm that way, then we will see in primary care that the prevalence of self-harm in girls and women is significantly higher than in males and boys. So the reverse is true in terms of the male to female prevalence in primary care to suicide. When we saw 3 to 4 suicides in males to 1 female suicide, the reverse is true about self-harm, about 3 or 4 times more common in girls than boys, and increasing as well. When we look at self-harm as a cause of death, i.e. attempted suicide, globally, then in most Western countries, self-harm is the second leading cause of death after accidents. Except in some years in America, one could see homicides, i.e. being murdered, as the second leading cause of death and suicide third. But if we look globally, then in females, it's actually maternal conditions that are the key killer of young females, teenagers, 15 to 19-year-olds. Whereas in boys who are 15 to 19, then traffic accidents is essentially the main mode of death, followed by violence, by homicides, and then followed by suicides. So that's globally. In the Western world, we clearly see that suicide is the second leading cause of death in young people, behind accidents. Now, is there anything we could do about self-harm? Up until about 2015, my answer to that would have been no. There was no evidence that any psychological therapies made any difference to self-harm at all. In 2015, we published the first meta-analysis, which has shown that we are not quite wasting our time with self-harm. Now, for those who may need a refresher on what meta-analyses are, in here we've got all of the studies that compared psychological therapies with controls, with some sort of a control waiting list or non-specific intervention. So all of the studies are listed here on the left. In here, in the middle, we've got the effect of these studies. So how much did self-harm reduce in a psychological therapy when compared to doing nothing or some sort of non-specific intervention? And the more to the left the overall effect size is, the more the greatest reduction in self-harm was actually seen. So at that point, the studies, the single study with the greatest effect on self-harm seemed to have been the type of psychological therapy which is called DBT, which stands for dialectical behavior therapy. Other studies with promising outcomes were CBT, cognitive behavior therapy, which is the Esposito-Smithers, and then MBT, which is mentalization-based therapy, which is by Russo and Fonagy. So that's 5 years ago. Now, this year, we published another meta-analysis with my colleagues in Vienna, which then looked at some of the updated studies. And interestingly, the effect size for CBT has reduced. So there was a large negative study of CBT by Michael Kaz in Switzerland that showed essentially no difference on self-harm in the follow-up period, except one has to say that the reduction, so everybody, both CBT and control groups reduced their self-harm, but in the CBT arm, self-harm reduction occurred faster. But when we looked at the actual endpoint, there was no difference. What happened in the DBT world, in the dialectical behavior therapy world, was actually the second study published, which was independent and done totally separately from the original paper. And they have shown that it was effective. So in fact, DBT at the moment is the only therapy in child mental health where we have 2 independently replicated studies which both show the same thing, that DBT is effective in reducing self-harm. Now, at the point of the publication of this meta-analysis, the second MBT paper was not yet available. It is now available, and in fact, the effect on self-harm was significantly smaller than in the original Russo and Fonagy paper in 2012. So when we meta-analyze these 2 studies, it may well be the case that MBT will no longer be significantly different from controls in reducing self-harm. But that's something that my research group is working on now. Now, apart from self-harm, of course, there are other possible targets for interventions. One of them is, of course, thinking about suicide. And for that, again, 2 psychological therapies stand out. One is DBT, as I mentioned before. So it seems to be reducing both self-harm and thinking about suicide. But here also, family therapy stands out. So all of these different family therapies with different effect sizes, you can see, but overall the effect size seems to be in favor of family therapy when it comes to reducing self-harm, thinking about self-harm and suicide. Now, I will take you through very quickly through risk factors for self-harm. You will be familiar with most of them. I might just draw your attention to a couple of recent risk factors that have emerged in the last few years. So one of them is really thinking about young people's sexuality. So worries about sexuality is something that we never particularly used to ask about. But now it is clear that being worried about your sexuality is something that is a very clear risk factor for self-harm. The other thing which is relatively new, and certainly what is new is how potent that is the family history of self-harm. Something that we rarely used to ask years ago, but it appears that if somebody in the family or a close friend self-harms, that's a very potent risk factor for the child starting self-harming. So what predicts thinking about suicide to moving to actually attempting suicide? Again, you will be familiar with most of these risk factors. What I wanted just to draw your attention to is a couple of new ones which emerged in the few years. One of them is body dissatisfaction. I can see that Bruce Clark is listed on the program. I'm sure he must have spoken about body dysmorphic disorder. Now, that is something that appears to be a very strong risk factor for moving the child from thinking about suicide to actually attempting suicide. The other interesting thing, which I really wanted to draw your attention to, is smoking. Now, I know that in the UAE, very few, or significantly fewer people take hard drugs or drink alcohol than in Europe. But smoking is a very common behavior, I think, in people, especially in males. And so I just wanted to draw attention that in study after study, smoking seems to be a strong predictor that moves the young person from thinking to attempting suicide. We don't quite fully understand why this is. It would be an interesting subject for somebody's PhD, I think. But just wanted to say that it's a known and replicated risk factor. And then finally, looking at risk factors for completed suicide. Again, most of you will be familiar with this list of risk factors. Perhaps one thing that I wanted to draw attention to is the adverse childhood experiences. Now, the literature on that really has exploded in the last few years. So we know now that young people who are looked after, i.e. removed from their biological families into some sort of foster care or state orphanages, then represent a super high risk group for suicide. In the UK, we really underestimated the importance of that group. And I'm doing really several studies, but one of them in particular, looking at preventing self-harm and suicide in very young looked after children, so 0 to 5-year-olds who are removed from biological families for reasons of severe neglect or abuse. Now, when the young person comes to A&E, how likely are they to come back? Again, years ago, the risk was estimated at about 10%. Later studies show that the risk is significantly higher. In the last few years, last 10 years, I think, the risk has moved to about nearly a third, nearly 30%. Again, people will come back if you follow them for a long time. And in A&E, of the people who come, about 1% will die in 10 years, and half of them will die of suicide. So not half of the ones who present, but half of the 1%, so 0.5%. The A&E research is interesting in the sense that it highlights the fact that violent self-harm, such as attempted hanging or drowning or jumping from heights, is really a very serious risk factor for completed suicide. And so in comparison to low lethality methods of self-harm, such as cutting or taking overdoses, then violent methods increase your risk of dying by about a factor of about 8. Last year, we had an interesting special issue in a journal called JCPP, which I helped to put together. And of all of the studies we had really interesting studies in that issue. I was very struck by this one, which I wanted to show you, which really looked at an interesting risk factor for suicidality in young people. And they looked at both ideas, so thinking about suicide, and attempting suicide. And what you can see on the right here is a map of relationships of young people within schools. So you can see that, and children with who are thinking about suicide or attempting suicide are in small red dots. So you can see the interesting thing here, really interesting thing here, is that young people who have suicidality tend to keep away from the majority of the children in school, but co-segregate with each other. So they have a little cluster there of red dots, which is something that we really have never seen in this striking, dramatic picture. But it's something that really has to alert us to the risk of a certain group of young people who are at grave risk of dying. So moving on to the current pandemic and COVID. When you think back to the risk factors of the onset of self-harm, repetition of self-harm, or suicide, you will see that a lot of the risk factors that I have mentioned to you about have been very prominent in the last few months during the pandemic. Essentially, we've got isolation. A lot more young people are isolated and lonely. We've got a lot more anxiety. Survey after survey shows that especially emotional disorders are particularly increasing in the population during COVID. We've got an increased risk of domestic violence, alcohol consumption, especially in adults who live with children, and increased exposure to social media. You've heard from the previous talk about the link between social media and suicide and self-harm. And there is no doubt that kids use a lot more social media now than pre-pandemic. So we were really interested to see what was the impact of COVID-19 on A&E presentations. We've looked at probably the largest study of its kind. We looked at over 2,000 presentations to A&E with self-harm, and we compared two time periods. So one was the March to April this year, during the peak of the first wave, with March and April last year, 2019, when there was no, obviously, a pandemic or COVID. We looked at under 18-year-olds, and we looked at all psychiatric emergency presentations, not just with self-harm. We managed to get together 10 different countries, including, I'm very glad to say, the UAE. And the population covered in our study was huge, was over 6 million young people. And we included 23 hospital A&E departments. So what we have found? We have found that the number of emergency psychiatric presentations, for any reason, has decreased significantly. So there was a substantial decrease in the number of kids coming to A&E for whatever reason. In 2019, there was 1,200. In 2020, we only found 800. And the proportion of self-harm presentations has increased. So if you look at all of these presentations to A&E, and then you look at the proportion which was for self-harm, then that proportion has increased substantially. You can see here that in this chart that even though the absolute numbers of presentations has slightly dropped, the relative, the proportion of these presentations actually increased very substantially. So here is, you can see that in most countries it was the case. There was an exception in Turin, in the northern Italy, where they had a slight increase actually in the presentations, and a tiny increase in Livingston in southern Scotland. But otherwise, it was a very consistent picture across the globe. What we have also found that the proportion of the young people who already had a history of coming to the hospital before with self-harm had actually increased. So the interpretation of this is that it's the young people who have never been to A&E that seemed, for whatever reason, to have been very reluctant to come. The ones who had experience of coming to A&E, who knew a little bit about the setup, seemed to be a little less frightened to come. And then we looked at the proportions of young people who had previous self-harm in the community, and we have found no difference in these presentations in 2020. Now, we really were wondering, and our hypothesis was that even though the overall number of self-harm presentations may have decreased, then the severe self-harm presentations, we would see more of that. Now, that was true in some A&Es. So we have found this, for example, in Edinburgh. But in most other A&Es, that was not the case. And so we concluded that overall around the world, there was no increase in the proportion of young people with severe self-harm during the pandemic. The other interesting thing was that we looked at different diagnoses in these young people. And one thing that stood out was that the proportion of kids with emotional disorders, i.e. anxiety and depression, has actually increased in 2020 in relation to last year. Now, we don't know whether that represents the overall increase in the emotional disorders in the population, or that young people with emotional disorders were more likely to come to A&E. But the fact is that during the second wave, one should really expect more emotional disorders in A&E than pre-pandemic. And then the final sort of important finding, I think, was that we have found that young people were significantly less likely to be admitted to an overnight observation ward in most countries. So in some countries, it's a mandatory requirement that anybody who comes with self-harm under the age of 16 has to be admitted overnight to be assessed the following day. That's a NICE guidelines requirement in the UK, for example. We have found that during the pandemic, we were much less likely to admit young people to these observation wards, possibly for obvious reasons, not wanting to expose them to the virus in hospital. Now, we have found several important negative findings. Overall, although Ben will talk to you more about this in terms of fine-grained analysis, overall we have found no evidence that children from deprived areas were any more or less likely to come to A&E, which was an important negative. We have found that ethnic minorities were no more or less likely to come to A&E. We have found, very importantly, that there was no difference in the chances of young people being offered a follow-up appointment. Admittedly, we included both phone calls and distance appointments as well. And also, we have found no evidence that young people were any less likely to attend their first follow-up appointment. Now, that is a really crucial thing to understand. The time of the greatest risk of suicide for the young person is the first week after they came to A&E with severe self-harm. So in most countries, there are policies to say that you must follow up young people following their presentation to A&E. And we were really worried that we will find that, with the pandemic, with phone calls and Zoom and Teams follow-up appointments, that kids will not be able to, will be less likely to attend these. But we have found no evidence of that, which was an important negative. So with all of these reductions in A&E, massive reductions in A&E presentations, is it conceivable that the reason why these young people did not come was because we admitted them to inpatient hospital? And the answer is no. We looked at hospital admissions in England, during 2019, 2020, and then in comparison to last year. And you can see that the actual number of admissions in England was actually very substantially down at the same time. So we have found just under 250 admissions during April in comparison to the usual over 350 admissions. So that number of admissions, in fact, was the lowest ever recorded in England. So, so the implications of this is essentially what we have found has profound implications. We know that during the pandemic, when young people experience substantial increase in emotional disorders, suicidality, self-harm, they are much less likely to come to A&E. They are much less likely to come to A&E with self-harm, and they are much less likely to be admitted as well. So we have created a situation where a lot of young people are at home, unable to access services. And that's a really important thing to understand for people who plan services. So the main take-home message from this is that during the second and possibly subsequent waves of the pandemic, one really should not create more A&E departments like we have actually done at the Maudsley. We had this extra A&E capacity. We should really focus on community services and trying to reach the young people who are at home, unable for whatever reason to come to A&E or be admitted to hospital. So developing community services is the key message for this second and possibly further waves of the pandemic. So I'll hand you over now to Ben.
Thank you, Dennis. I know we don't have a lot of time here, so I'll try not to rush everything. Let me just try to share my screen and pick up on the presentation. Okay. So drawing from these results from the main study, there were some questions that we were asked to provide a clearer picture First of all, our study looked at March and April 2020 data and compared with 2019. But were we actually comparing the effects of having a global pandemic or not? Or are we comparing the effects of lockdown, which was introduced in many countries? Because these are co-current and we want to try to separate them. And how did these measures contribute to our findings? Is it as a mediator or as a predictor? And when lockdown measures changes and updates, what does it mean for self-harm in children and adolescents? So the next slide, we summarize some of these most prominent effects of lockdown policies. We won't have too much time to cover all of this, but I guess we can just go through. It's quite straightforward. So school closure, obviously, disruption to education is a big thing for many children. And this was back in March and April 2020. Now it might be different because a lot of schools are open in many countries. But back then, school closure was such a sudden, abrupt thing for many children, and it might be hard for them to adjust. And also, it might be hard to see that for half of the parents felt very hard to support the homeschooling, and also the services of healthcare services, they're not adjusted to the whole pandemic. So a lot of assessment and care plan reviews might not take place. And we might see a lot of physical distancing because school is such an important platform for peer contact. And without school, there's basically no contact and children can't go everywhere. And leisure activities and other entertainments might be very limited. And living in small places, a living place might be bad for the family as a whole because stress in parents is actually a significant mediator to children's emotional behavioral problems. And we might have extra concerns for those with pre-existing mental health conditions or those who are looked after. Also, multiple studies have raised concerns of inequalities of school closure. And also COVID-19 has had the greatest impact on the most economically deprived. And we want to see whether this actually lead to a reduced access of professional support. But also we have to keep in mind that these measures are constantly changing and they vary internationally. So different countries have different measures. And most of all, it's very subjective. So how do we combine this with our results? We found a tracker called OxCGRT, and it's a tracker developed by a research team in University of Oxford, Blackford School of Government. And basically what it does is collect systematic cross-national information and standardize composite index of these measures to give us a sense of how stringent and restrictive the lockdown policies are. And these are the 9 policy response indicators, which is common policies that have occurred in many countries. So using this information, we're looking at the mediator role of stringent policies and also the predictor role of stringent policies, and how do these affect the presentations and the clinical profiles of those who presented with self-harm. So essentially what we found is a very significant mediation model. If we look at the green line, this is the direct effect of year. So let's go to 2020, we see actually a positive relationship. There are actually more emergency psychiatric presentations, but this is overshadowed by the mediation relation through the lockdown stringency. So the total effect we're seeing is actually negative. We see less emergency psychiatric presentations. And the same thing goes with self-harm presentations. We expected more self-harm presentations if there was no lockdown stringency. But in fact, in reality, that is the mediation that exists. And we see less self-harm presentation this year compared to last year. And this is interesting one. It's about a proportion of self-harm presentations. So essentially it's telling us how important or how major the effect of self-harm is within all the emergency psychiatric presentations. And we're seeing a significant positive mediation relationship, but the positive relations between year and the proportion is not significant. So basically what we're saying is lockdown stringency is doing all the work here, is mediating the whole relation. After we have established the mediation relationship, we can look at the effect of self-harm of stringent policy as a predictor on how do children from different deprivation levels present. And if you look at here, it might be difficult to see, but like the darker lines, these are the more the less deprived families, and the gray lines are children from more deprived families. And we see two distinct trends here. As the lockdown got more stringent, people stay more home, we can see that there are less children who are presented for self-harm from the more deprived deciles. And in fact, children from the least deprived deciles, they're more likely to be presented. So this is interesting because if we looked at, just pick out any two deciles and compare, we might not see the same relation. So let's say, for example, this is the third decile, which is supposed to be more deprived than the seventh decile. But in fact, the relationship is inverse. We see less children from the less deprived deciles to be able to present it as NA for self-harm. So which is why that might be the non-significant result in our main study, that we see that there wasn't a relationship. But if we look at the patterns, it's actually very distinct and different, and it's very interesting. If you look at as a predictor, we can see there are more male children get presented for self-harm when it got more stringent, and there are more looked after children get presented. And we also have a record of the precipitant of these self-harm presentations. So as we can see, out of all the precipitants, social isolation become more likely a precipitant when stringency increase, which is, in other words, it means social isolation is a more important factor to the self-harm, whereas school pressure and row with a friend got less likely, which makes sense because there were less chance for them to interact with their friends and to be in the school, and there might be a higher level of feeling lonely. So just a recap of our findings, it seems that lockdown stringency mediates the reduction in psychiatric emergency and self-harm presentations. And also the rate of these presentations seems to have increased if there was not any lockdown restriction I received from the mediation model. And we might also want to investigate in the future the potential psychosocial inequality and how do children and adolescents from different deprivation levels, how are they affected by these stringent lockdown measures? Are they affected differently? And we might also want to consider this social isolation as an important factor, because this is very evident that they got more likely to be precipitant when you get more stringent. So what should we do? As Dennis mentioned, help seeking in children and adolescents who self-harm is very rare. And in fact, I think according to a systematic review pre-COVID, there's only about 50%, and this has likely got worse in these stringent lockdown restrictions. So we need to reach and support those with severe mental health needs. How do we do it? So first of all, policymakers and commissioners, they should prioritize funding and develop community mental health services, because we need to find a pathway that can reach these individuals. As we can see, like some children and adolescents, they might be less likely to be presented for their self-harm problems. And we can also think about how to reduce social isolation, because this seems to be a major factor nowadays. And stringent lockdown measures we should make it as short-lasting as possible, because we want to avoid the build-up of these psychiatric risk. And when we do it, we want to provide clear rationale. We want to tell people why we do it and how long we're going to do it, because otherwise there will be public confusion or fear or misconception. And these are likely the barriers that prevent people or children to be presented for their problems. And research-wise, we may look at specific policies. So we mentioned the tracker, and it actually has a lot of components, and we can look at how specifically each component, for example, school closure, because nowadays we can see this second wave of lockdown, many schools are open in other countries, and we get a new set of data compared to March and April, because back then we don't have school open, and how do self-harm presentation or psychiatric presentation vary in this situation is different from back in March and April. We might want to look at specific components, and when meanwhile we might want to look at the perspective of specific deprivation level, and how do the socio-economic status of the family affect the presentation. And we want to prioritize the vulnerable population. As we can see, male children might have more self-harm problems. It is possible, it's potential. We can't have a conclusive evidence, but it's interesting to look at, because that is as the inverse of what the self-harm problem is in pre-COVID. And also looked after children might be something that we want to look at. I hope I covered that in sufficient way, and thank you for the time, and this is all.